Good morning, and I'd like to welcome you to this inaugural conference on depression on college campuses. My name is Earl. I'm Vice Provost for Academic Affairs and Dean of the Graduate School, and along with John Greden, serve as co-chair of a planning committee that has put this conference together. It is our pleasure to welcome you to Ann Arbor. We are glad today is Thursday and not Wednesday, because we know that a number of you would have been stranded otherwise trying to get through at least several regional airports. But it is a delight to have you here, and we're glad that you've agreed to engage us in this very, very important conversation. A conference like this would not be possible without the mighty support of a wide range of individuals, and over the course of the next day and a half, I want to do my very best, and John and I both, to thank a number of people who actually assisted us in this effort. What you will see in the next day and a half is sort of the outcome, but there were numerous conversations. And indeed, let me start by first thanking the participants, those of you who agreed to take time out of your busy schedules to come and to really engage the broad community on the larger topic of depression, and also engage us in a conversation about then innovative strategies and best practices. But the subcommittee then, and the committee that helped to plan this conference, included Paula Allen Mears, Jim Bean, Tom Carley, Frank Cinciola, Bonnie Haggerty, Matt Nolan, Rossi Ray Taylor, Todd Sevick, Bob Winfield, Evans Young, Rachel Glick, Dan Pack, Karen Wixon, Brian Rogers, Pamela Reed, Tamara Gay, Bill Kotowitz, Carol Boyd, and Bob Hatcher. And I'd like to thank all of them for assisting us in putting together the overall program, and to really talk about the strategy that we wanted to adopt and trying to convene this year's conference, and also outlining plans for subsequent conferences, knowing that there are many different ways to start. And what we decided to do this time around was to start with sort of a series of interconnected broad questions, hoping to flow into more pointed questions over the next several years. I also like to draw your attention in the front of the program to the number of co-supporters. What I'd like to note is that the entire university community, the University of Michigan community, embraced this idea. And there have been supporters of all kinds in terms of in-kind support as well as financial backing. And what you have on the front page of those who have lent their funds. But I would like to also draw your attention to the fact that this is indeed a university-wide effort. And we would like to acknowledge the entire university for its support of this very important conversation that we're about to engage in. And then I'd like to offer special thanks to two individuals who have spent a lot of hours over the last month and a half trying to pull this all together. Lynn Dumas from Rackham, and Sarah Newland, who works with John in psychiatry. The two of them have put together a program, organized a number of events, and will assist us in making this event as smooth and transition-free as possible. And so Sarah and Lynn, I know Lynn's at the table and Sarah was walking around. At some point we will bring them to the front so you get to see who they are. But just join me in thanking them. And there's much to be said on the topic of depression, and you will hear numerous commentators and speakers talking about different aspects. We now know that 1 in 4 women and 1 in 10 men can expect to develop depression over the course of their lifetime. We also know that it continues to be a disease and illness that is afflicting more and more of the world's population. And in the university settings, as we embrace more and more of the world's populations and deal with different cultural, national, age, gender, racial differences, we also know that depression cross-cuts all of those differences. And so as we gather here and explore in a common space many of the themes, one of the things we also can take heart in knowing is that while the problems are considerable, the challenges are also considerable, the possibilities for coming up with solutions that work are also considerable. And so I thank you for helping us to really launch a conversation that will be useful. I will, and I will have many other opportunities, but one of my jobs as co-chair is to make sure we stay on schedule. And so as part of that, I'm going to shorten a few things I was going to say to get us back on a schedule in such a way that you are able to engage in this conference in the ways that we had anticipated. So it's now my pleasure to introduce my colleague and the Provost of the University, Paul Courant. Paul is Professor of Economics and newly appointed this year as Provost. Paul.
Thank you, Earl. Keep you on schedule. You know, this is an interesting, extremely, I don't have to tell you that depression's important, right? You wouldn't be here if you didn't think it was. We as academics, we in universities, we study things, we want to understand them, we intervene, we want to improve matters, and here we are studying and intervening on our own behalf. We're talking about depression on college campuses. Specifically, this conference is addressed principally to issues involving students, but we all know that faculty, staff, researchers, I mean, this disease is not new to the academy. And indeed, as you think about an academic career, you spent nights up late with somebody when you were a sophomore or a junior who was really in bad shape, and nobody could quite figure out what it was. And maybe that person you spent nights up late with was you. And similarly, that goes on throughout the life cycle of the academic. I have no idea, you'll maybe tell me at the end of this conference, or I should have talked to John about it, whether academics are unusually prone to depression. But the pressure that we put on ourselves and each other as part of our perfectly noble ambition to understand and change the world, that's not a bad thing to want to do, but we evaluate each other all the time. I have a dim recollection that it's not especially good for people to be evaluated and be evaluating all of the time. Makes us, I think, very open to the ravages of depression. So without going into much detail, since again you know the details better than I do and you'll be talking about them more over the next couple of days, here's a vision to imagine. Right? And I think about this on behalf of the 39,000 students at this university. Suppose that depression just weren't an issue for anybody on a university campus. What would that be like? And just asking that question and thinking and imagining the difference between that world and the one that we live in, right, gives you some idea, I think, of how prevalent, how serious we know this is, and how important the work that all of you are doing is. And so I'm proud to be part of a university that's addressing these issues in this way. I'm extremely grateful to my colleagues Earl Lewis and John Greden for putting on this conference.
Good morning. I'm John Greden, and it's my task to now launch these 2 days after these introductions that you've received. I don't need to say anything more other than that I will also try to stay on time. But Earl told me that to save time, I should give my own introduction. So this is a note for those of you who can see it that my son wrote in 1983 when he was asked to write a job description for school, and it says, "I am a doctor, a psychiatrist." He had to work to spell it, but he got it. "I come to work and just fill out papers and tell my secretary to get me some chocolate milk. I like my job a lot. It's also a good pay. I see patients a lot and give them prescriptions for medicine. Sometimes I go into the hospital rooms to see patients. I like my job very much." I do too. And now this is one more thing. My goal today is to tell you a story, a bit about where we are. These are my two grandchildren. That's Julia. Says, "Now, Ben, I'm going to tell you a story like Grandpa John does for us." This story is about depression, and I'm going to give you first an overview, secondly the impact on us, focusing upon college campuses, third an explanation of why we are doing that. This is something that we intend to continue in the future, and then most importantly, how can we respond? And we will have time for discussion during the course of these 2 days, but probably not after this. So the big picture Cliff Notes overview is this is common. You've already heard it. I'll go through this. You or someone you know, no matter what level you are at, professor, assistant, research scientist, student, you know someone or you personally have this just because of the prevalence. It's treatable, and our goal today is to try and disseminate knowledge. This is not going to be the focus of this conference. I'm sort of a translational neuroscientist, but we're not going to do this in this conference. At some future time, we may have a bit more focus. But I still feel that part of our problem about depression is misunderstanding about what it is. It's an illness. It's a disorder. And at some point, it starts here, in there. And this is actually a slide that, for those of you who can see it, I'm sorry it's a little washed out in the PowerPoint translation, but it's an actual very early slide. It's almost 2 decades ago now when the first PET scans were showing the difference between brain metabolism of someone who was depressed, manic, and then depressed again in sequence. And the evidence has since accumulated profoundly over the past 2 decades, including the information gleaned during the decade of the brain. We know a lot about this now. And I think at this juncture, when I say that, that's to give a foundation. You'll hear all kinds of things from me that indicate that that brain is influenced by everything that goes on around us. That's the environment. These are symptoms. They're written in some of the materials that you have. I'm not going to spend my time on it today because, first, I think many of you know it. People get sad. They get blue. They lose interest. They no longer enjoy things. They essentially have changes in appetite and weight, and it can go up or down. 2/3 lose, 1/3 gain. They can have alterations of sleep. 2/3 have trouble, 1/3 actually sleep too much. They can actually get motor types of things. They get agitated, they walk around tense, or they're very slowed down and almost not moving. Voices change. They end up having multiple physical symptoms, lots of complaints of pain, GI symptoms, diarrhea, constipation. They feel worthless, guilty. People try to reassure them, it just doesn't seem to help. They have trouble thinking and concentrating. They can't make decisions, even such things as what do I eat, what do I put on this morning. Recurrent thoughts of life not really worth going on. Those things are well known. And what is actually now not so well known is the fact that there are understandings about a number of these symptoms. Not all, but we're getting there, and we know the linkage to other things. Now, in 1990, the World Health Organization tried to redo their provisions for understanding the burden of disease in the world, the global burden. The prior nomenclature had looked at various strategies and essentially had decided that because they were based on things from the 30s and 40s when infectious diseases were still more rampant, that they needed to redo them. And they did. And they came up with 2 new measures. And they themselves were stunned by the results. What they discovered, lo and behold, is that arguably, in my version, they did not list them together, but unipolar and bipolar depression are arguably the most burdensome disorders in the world, by my interpretation. Why? Unipolar is 4th in one of the measures, namely disability-adjusted life years, and bipolar is 6th. Unipolar is actually 1st in years lived with disability. Most people go on. In women, it's 1st regardless in the framework of this. And what really stunned them is that 11% of the disability in the world due to the 100 most important illnesses that they studied was attributable to unipolar clinical depression all by itself. That's a frightening start. How do you explain it? Well, you heard Earl already give the intro to part of what I'm going to do. And in this slide, you're seeing what I have thought a lot about as far as explanations, not because I cared about the little boxes, but literally because I felt it gave us targets as to how we should approach this in the University of Michigan Depression Center and how literally campuses ought to address this. So let's look at the issues. Number 1, widespread prevalence. You already heard it. 17% of the country has a lifetime risk for this. That's a lot. It's roughly 1.7 to 1 ratio of women to men. The symptom onset actually peaks during 15 to 19. You'll hear me say, though, that diagnoses don't get made. That's the underdiagnosis and undertreatment that we face, and I'll actually show you something. The genetic vulnerability and the stress genetic interactions are well documented now. It's no longer a mystery. We do respond to stressors. We do respond to bad events, deaths, financial distress, breakup in relationships. They activate the same things that we are talking about in the symptom profile that I've given you. Recurrences and cycle acceleration, a speeding up of how frequently they come, and the severity of each episode then become kind of a prototype story if untreated. And that's again back to box number 3, because so many tend to be untreated. We do little to prevent recurrences. We actually do too little as a society to address stigma, and as a result, it's one of the variables, not the only one. There are other factors, and you'll hear about them in some of your sessions during these 2 days. But we have poor adherence. People don't stay with the treatments that are actually recommended. And most recently, in the past 6 or 7 years, as neuroscience technologies have gotten really sophisticated, in magnetic resonance imaging and PET scanning and SPECT scanning and a variety of other approaches have become quite nice, a piece is starting to emerge which isn't so good, which is that over time, with chronicity and severity, you can actually document degenerative changes in selected regions of the brain, the hippocampus and the amygdala, and that probably is one of the real reasons why we see more burden over time. If you look at that picture, I've not given you a very good start. And that's Julia again. Oh no, Grandpa, this does not sound like a good story so far. But there's good things to come. And if we start here today and tomorrow, we can actually change some of that profile. I've already said most of these things. Why focus on students? Well, it starts at this age. Underdiagnosis tends to appear because up until then, there haven't been symptoms. So it's not that it's worse for college students. I don't know the data on this, and some might. I don't know that we know it. But I actually do think that that's when it starts appearing symptom-wise. That's when we're not looking for it. Therefore, underdiagnosis becomes a problem. Stresses peak, and I'll comment on this. Genetic vulnerabilities. We have clinical and payment gaps. We've had some highly publicized suicides on college campuses, and we've got stigma. Probably one of the more important reasons, however, why Earl and I decided back when we were involved in the presidential search that this would be a good topic for us to address, is the fact that we really, I think, need to recognize our future. And so we decided this would be something that we would address simply because this is our youth. We could have a conference here today on geriatric depression, and it would be quite relevant. But let's look ahead. Let's try and address these things for the next generation as well as us. Very fast, walking through the peak onset of symptoms is 15 to 19. Now, if I can't do this up here because the mic is what's carrying to you, so I like to walk around when I talk, but I can't. And so if I were doing it, I would openly sort of give my analogy of I'm walking down the street and I have a propensity for diabetes. I don't suddenly go, I just got diabetes. It happens gradually. It happens over time. It's that story with hypertension. It's actually that story with depressions, with the depressive illnesses. And in essence, what occurs is these things tend to happen in incipient fashion. They happen gradually. They come, they go, but they get worse. The average age of diagnoses, as has been documented by DBSA data, the Depression Bipolar Support Alliance, actually ends up being in the range of 27 for clinical ones, and 21, it's earlier because it's easier to diagnose for bipolar. The average age of treatment, who knows, decades. In some cases, not at all. Let me illustrate that to you. I won't do this in the interest of time. I love to do a little exercise where I make everybody stand up, but it adds a few seconds. So if all of you now imagine that everyone in this room has one of the depressive illnesses of one form or another. Most of you would have unipolar, some would have bipolar, some would have some variance with phobic patterns or panic attacks or other things thrown in. If I then said, how many of you are diagnosed accurately if you end up going to the health system in America? 50% of you. All the people in this side of the room, sorry, you don't even get a diagnosis. Our health system fails to even make that. You got 30% who end up the clinician basically says, oh, you have a diagnosis of some sort of a depression, probably documented on a record somewhere, and yet, for inexplicable reasons, sort of says, we won't treat, we'll watch, or you refuse in some case, but it's no treatment. 10%, now you're getting there, or at least making progress. You end up receiving a recommendation, usually because it's in a non-psychotherapeutic setting, a primary care setting. So somebody says, let's give you a medication. What do you get? You get a benzodiazepine. You get Xanax, Ativan, something like that. They do not work for depressive illnesses. 5% of you now are starting to get appropriate treatment, but it's usually too little and essentially not long enough. And that means by country's estimates, and by the way, these data are a bit old, and the current estimates are that it's probably gone up to about 7 or 8%. Some see that as encouraging. I still see it as horrifying. And I think that as we look at these things, we're really talking about optimal treatment, including maintenance when it's indicated, being given for a very small percentage of the people who have these diseases. So why does it occur in colleges? What happens if you happen to be 18 years old and having gone off to the University of Michigan or Harvard or wherever else, and you essentially have symptoms of the type that I gave you? What do you get called? Adolescent adjustment reaction is more common for the 15 to 16-year-olds, but it still is a carryover type of thing. Starting college is far more likely for our group. Oh, you've left home. It's understandable. Of course you're sad. You moved from home. You have grief reactions. You left your girlfriend behind. This is also the time when beer drinking and other kinds of things starts, as well as other substance abuse patterns. What do? Not only do they do not necessarily good things to the brain, and probably even worse things for those who have the vulnerabilities, they essentially alter sleep patterns. And some of you who are interested in this can have an opportunity in one of the workshops to hear Dr. Armitage talk, and she's going to try to address college health and sleep. And what also happens is that in dorms and everything else, it's referred to as moodiness. And certainly it's moodiness because it's a mild stage, but it's moodiness with irritability and with a variety of other symptoms. And nothing in this list suggests that anybody is looking at the variables that probably we now know we should be looking at, which are what is going on with you in the combination. Now, stress is something I mentioned. I want to look at these. Stress is something that we've known a lot about since Selye described it way back at the turn of the century. In 1953, our focus was on stress in the adrenal glands and what it did with the body. We learned a lot. We moved up in the 80s. Everybody shifted to the brain. And we now know, and I'm not going to give this to you, but we've characterized all of those mechanisms. Corticotropin-releasing factor is the little agent that sets off the cascade. We know where the feedback loops are. That aspect up there is pretty important, ladies and gentlemen, but it also is not the whole story. And that's why this has to be tied together. And what we've now learned is that over time, things like post-traumatic stress disorder, chronic depression, substance abuse, actually probably seem to combine and do that little not nice story that I gave you earlier about the possible hippocampal degenerative changes. There is actually interactive aspects. So if people are depressed and drinking, it's even worse. So now if you sit and look at that story, it's not so good. That's one stress story. That's the background. You've had now a 1-minute lecture on stress. Secondly, now let's ask what is going on. I've given them to you already. In addition to leaving home and those family, friends, and hometown and new settings, there are all the financial worries. Not everybody these days can look sanguinely at college and say, oh, this is a breeze, it's fun, best years of your life. They build up debts. The average, I don't know the campus figure, Earl might, but the average medical student now graduates from the University of Michigan with a debt of about $105,000. That's a long time to pay that off when you start asking, now I'm going into an internship and a residency where, other kinds of things, they all worry about it. You have academic pressures that increase. Reading loads go up. Some actually struggle with learning disabilities. Career choices now are there. We've got job uncertainty in the current climate. We've got social and sexual stressors. They're big. Biological stressors also peak. I mentioned it. Alcohol, caffeine, nicotine, and, sadly, diet products. For anybody who knows somebody or personally is in this category, Bad stuff. Bad stuff. The ephedra story is not good for people with this. It's a stimulant thing. It produces a surge in those neurotransmitters that we're actually playing with, but in the process, in its cyclical pattern, it depletes and it does other things. It is not good for those with depression. Chronobiological shifts and sleep disruptions are big deals. And, you know, in essence, some of us have experienced jet lag. We've gone to Europe, for example, or Japan. Now picture yourself, we do that because we then have a biological clock that says now you've got to adjust to a new time, and we don't do that instantly. It takes a bit. And when we're out of sync, symptoms get accentuated. Now picture what happens if I'm a college student and I've been on campus for 3 weeks, and I basically am starting to get a little comfortable, I think, and I've got a few friends, and everybody says, let's go out and drink some beer tonight. And I do this, and we go to wherever. And at that point in time, I come home and I actually go to bed at 3 in the morning. And I sleep until 1 the next afternoon. And then I get up, and of course, at bedtime the next night, now this is a Saturday, I'm not very inclined to go to bed. I just got up at 1 o'clock. And at this point in time, I stay in and do it again. And so now Monday morning, I'm supposed to get up and go to classes. I mean, let's just say that's a routine, and I'm trying to do these things over the weekend, and I don't feel like getting up. Maybe I forced myself. In essence, if you just think about what's happened, jet lag isn't because you've been on the airplane. Jet lag is the chronobiological shift. It comes from transmeridian travel when you do it that way. It also comes from changes in sleep pattern. And you've gone on about a 4 or 5 hour trip, if you will, every weekend. And so if you flew to Europe every weekend and you felt pretty rotten, you'd probably say, oh, I think I understand what's going on a little bit, and you'd attribute it to that. But our students don't necessarily make linkages because that's almost seen as a way of life. So my little airplane there is an illustration that for those of you who really feel this is relevant, there will be a workshop for you here. There are also unaccepted drugs, and that list is there. You could also add others to it, but those are the ones that are most common on college campuses these days. And for those who have the genetic vulnerabilities, it's worse risk. Tie this together now. So Grandpa, in this story, how do I make sense of these two things that we're talking about, namely stressors and the other factors? So I go off to, first I have a divorce in my family. And where is that button? And this, by the way, is normal mood. I'm doing well. Just get rid of that arrow. And I'm fine. Right there, that level line. Anything below that is depression. I'm not going to illustrate on this particular slide manic symptoms or hypomanic symptoms. These are stressors, and these are ages, so I'm getting older. Divorce in the family. My parents really struggle. I have symptoms. I stop playing tennis. My grades drop. I slam doors. Everybody appropriately attributes it to what's going on. I end up actually going off to college. I go to the University of Michigan. It's leaving home. I have more symptoms. Actually, I have real trouble in my first term. And maybe I have to think about dropping out. I may not make it, even though I've been a very good student up until now. Maybe I survived things, but my grades are off to a horrible start. Life is already getting a little rocky. I can assure you, ladies and gentlemen, sadly, that in most cases, if I happen to see anybody there, it would be a school counselor who would be concerned, or a teacher. Here it might be roommates who say, why don't you go to student health? The pattern still tends to be to go back to those terms I was giving you earlier. Not to ask family history, not to sort of put it into total context, not to pursue what might be going on here. Let's get an early start on it. And then I end up graduating, or I have a broken relationship. Now I'm actually across the threshold officially, but nothing gets diagnosed. I put it together for a few years. I get a good job, but I get a bad job evaluation. Maybe because I've already started going into an episode and I didn't understand why, but that really throws me. Now I end up actually having, the sort of joke that I use is it's winter time and I go into a skid and I bend my fender or something like that. No big deal, but it actually sets off all little stressors then start having, and pretty soon there are no stressors, and yet I'm in a cycle. Now these are the people in the years that I ran a depression research unit in a hospital setting. That's who you see. And that's not the story. That's why we're here today, to talk about depression on college campuses. We could do this in high schools if we wanted to, but we've got to start with a focus, and this is ours. We have gaps. You can hear about those. I'm not going to talk about them. They are very real. And that's actually probably what people tend to focus upon. I think we need to. We need to fix these because people fall through the holes. And there are conference speakers that are going to address that. But if you looked at why, if you ask people why they don't seek treatment, oh, I'm going to do it myself. It'll get better. It's too expensive. I don't even know where to go. It wouldn't do any good anyway. And I've added another one on my own that's not in this survey, but I'll do it myself in a different way, solving the problem, and I'll do it medically. And I'm going to talk about that a little later, namely use of herbals. So how can we respond? Change to Chapter 4. We can detect earlier, treat earlier, prevent progression, counteract stigma, and I'll give you my own little personal proposal. Establish a network of depression centers. I'll come back to that. Detecting earlier. Screening. How do we do this? We just ask the right questions. Believe it or not, the sophistication is there. We know enough about these disorders right now so that we can ask. We can screen, and we can be reasonably effective in identifying those at risk. People can do it on their own if they're still sensitive, and we understand that. The student health and primary care settings are now picking up on this. Their response to this conference from around the country was really heartwarming. It was sort of reassuring because people said, we've got a problem, let's do this. And a lot of this is student health. It's not necessarily mental health people. I would like all of the student leaders in this group to encourage and accept that. We need some push sometimes. The pressure to do things in medical and health systems sometimes comes from the consumer, not necessarily from the top down. We need to recognize warning signs, and we need to know our family histories. We need to know our risk factors. I have risks of cancer in my family. I have risks of cardiovascular disease and cholesterol. I pay attention to those. Why? Because I know them, and because that's just what good people do if they're smart and want to have healthy lives. We need to incorporate these disorders into that same framework. We are making progress. You're going to actually hear some of the data, or those of you who attend that workshop, from the Kansas State assessment, where they're watching. They have data to show that the percentage of students seeking treatment, reporting suicidal thoughts, etc., are surging, doubling approximately in just a small stretch of time. Is that because of awareness? I don't know. I think it's a factor. I think it's actually not just that things are getting worse, but I do think that we're making great progress against stigma, and that's partially why we want to keep the momentum. 80%, more than 80% of the directors of counseling centers reported increases, so this is not just a single university. This is a pattern around the country. And I don't see it as just, oh, there's lots more of it. I think it's potentially a factor. We had 9/11, we had other things, but I do believe that we've also got an awareness that, geez, I better get some help. Treating earlier is important, and what should we know? Well, coping with stressors is important, but it's been my sense through the years, and when I've talked mostly with medical students, but sometimes with the undergrads and others, that they all want to attribute everything to stress. And I kind of have given you that viewpoint of mine already. It is important. But stressors are going to come, and we are not going to prevent them. So what we're really talking about are coping strategies. How do we manage to deal with them? How do we prepare? Some of the people on this campus, Rick Price and his colleagues, have actually worked on strategies. If you know you're going to lose your job, you can do something to help people prepare. An intervention actually lessens the risk of going into an episode. You can do those things. Well, we can also do them in college dorms. We can identify those who have the vulnerabilities and help them. What's known about clinical things? This is not a clinical outcomes lecture, but I thought I would be remiss if I didn't give you a quick summary. Antidepressant medications work much better than no treatment and are safe for those who have depressions. Antidepressant psychotherapies work better than no treatment and are safe. And those are, in these particular arenas, the cognitive behavioral and the interpersonal. Not every medication nor every psychotherapy works for every person. And we need to get more refined in our research to pick it out. Not every antibiotic treats every infectious disease. We need to have the same recognition here. Not everybody responds to the same thing. We're gaining. But at this point, severity, family history, and prior episodes should determine who gets treated, not provider preferences. We still have that. That's my own criticism of my own field. You go see somebody who believes in psychotherapy solely, that's what you get. See somebody who believes in medication solely, that's what you tend to get. It's time for us to change. Maintenance antidepressant medications prevent recurrences for those who have them. They do work. They're rarely used. And you can stop that pattern by essentially plugging these things in. Lifestyle makes a big difference. Exercise is very important. I'm not going to give you another part of the story, but in the past 5 years, something I didn't have in my nomenclature 5 years ago was the term neurotrophins. And we've learned, neuroscientists have learned, that there are components that we have that previously were relatively unidentified that are actually sort of the plant food of the brain. You need those substances. BDNF stands for brain-derived neurotrophic factor, for example. And there are 5 now that have been identified, and there will probably be more. And what happens is they change with certain things. Stress drives them down. Exercise pushes them up. And one of the interesting things about it is that sleep impairments probably also are seemingly altering them. Now we start getting all of this story. I've used the phrase that the mosaic starts becoming a picture. These things start tying together. Because there have been reports for 3 and 4 and 5 decades that exercise is helpful for those with depression. We ought to be encouraging it. Regular sleep, avoiding the things that make it worse. Tobacco, by the way, is a special risk for women. Women who have a propensity to depression tend to smoke more, probably because the nicotine is doing something to release those very neurotransmitters that give them short-term relief, but it actually seems over time to accentuate the risk of having longer-term problems. Bright lights, phototherapy for selected people. Won't go through the circuitry, but Dr. Armitage might answer some questions. And then finally, this amygdala, that's a phrase that I'm using sort of glibly, talking to your amygdala. That's the location for fears. A lot of people these days are responding to fears. You can dissuade yourself from those things. You can sort of put it into reality. Talk to yourself and essentially say, oh, is this really realistic? We have a lot of things that we have to deal with, but I'm not so sure we ought to be in the midst of campus things really immobilizing ourselves because of events that are going on in the world right now. They're not good, but essentially they're also in a day-to-day routine, not what should be costing us sleep. And then stigma, and I want to launch into that just briefly in my few remaining minutes. The science basically says, this is David Satcher's report in 1999, an elaborate report for those of you who are interested in it. Mental illnesses are physical illnesses, and I've been kind of trying to drive that point home. But society still says depression is a state of mind to the tune of 1/3. 1 in 3 respondents saw it there. Now, we've made progress. They changed the terminology in some of these surveys, but 20 years ago, 50% saw it as a moral weakness. That's what the term was then, and 50% saw it as an illness. It's now 2/3 that are sort of in the ballpark. We're making progress. That's actually what I think is important as we address these things, but we've got a long way to go. Not accepting stigma-perpetuating behaviors to me means becoming active participants in this struggle, and I have my own viewpoints about how we do this best. I think we need to resist safe labels rather than encouraging them. It doesn't help to change the name. It just makes the problem worse. In fact, it stigmatizes. So when we hear, well, if the diagnosis is accurately depressed, oh, you're stressed, you're exhausted, maybe you have hypothyroidism, maybe it's blood sugar. Those kinds of patterns are understandable in the context of society, and frankly, I know why we tend to do it and why patients and doctors do it, but they don't help. They actually keep it going. This pattern of physicians and clinicians saying, well, we'll try this for a bit. If you heard that message, what do? You get a little side effect, I don't like it anymore, and you tend to leave it. Treatment switching is not a good pattern for those being treated with depression should they require antidepressant medications. I don't like the fights between psychiatrists and psychologists. We're different in our work, and then we're different from everybody else, other parts of the health profession. And I don't like the current emphasis on herbals, and I believe it's substantiated with ample evidence. I'm not picking up on something. I would like it if some of them really were established and shown to work, because it would reduce costs. But just picking on one, There are 12 million Americans who are currently out there using St. John's wort. It's just slightly less expensive than Zoloft, for example. It is a medication. It affects the same neurotransmitters, serotonin. It does have side effects, and it has limited proof of effectiveness. Why are we using it? I think it's predominantly stigma. I can hide this, but somewhere along the way we ought to be doing things that work and that prevent progression. What else can we do? Join partnership groups. Advocacy groups are here today. You'll have representation. Rick Burkell's already here, I saw. He's the executive director of NAMI. There's a panel this afternoon. I would love it if we could get some students involved in these efforts and really build some bridges to campuses around the country. Media and videos are part of the dissemination. You'll see one after I'm finished. Corporations and foundation relationships, they pay the bills. And essentially we need to work on them. If any of you have CEO fathers, tell them to call me. Health screening, I've already mentioned, and it ought to be part of our routines everywhere. And that includes in all primary care settings and student health services. And then yesterday I was actually in Washington, D.C., giving a whopping 3-minute time limit presentation to the President's New Freedom Commission on Mental Health, and my agenda was advocating for a national network of depression centers. And essentially, I'll come back to that just a little bit, but I think it would help us. Joining student outreach is important. Support groups, internet updates. We've given you a website on here. That's the Depression Center one. After thinking about this, I looked at the handout this morning and I sort of thought, no, gee, we should start a special column, and maybe we'll do that. That will be addressed to depression on college campuses. Meet the expert sessions and symposia. This one today we see as the first of an annual one, and we would like your ideas for topics for the future. Quote respected figures. That list is getting so long right now. There are all kinds of people, and some of them are outdated, but there are just all kinds of people who are now openly talking about their depression. And I think that's progress, and we should encourage it. And when somebody says, well, you can't do that, I mean, I think many are. Communicate accurately means proper terminology. It's an illness, it's treatable, go see your clinician. That's what you tell your fellow student, that's what you tell yourself. A matter-of-fact approach works better. Correcting errors when you do hear them is really important. People do respond. And then a proactive involvement, I think, is relevant. I've used this term because I kind of liked it in the framework of having a family history cancer. I found myself being moved when I saw a few years ago at a University of Michigan football game, and they had basically a halftime function, and they asked all of the cancer survivors to come out on the field. And there were thousands who walked out and proudly waved their hands. I want to see that someday for depression and for the depressive illnesses. And I think cost benefits get to be there. I believe personally, and it's a viewpoint, and I'd be glad to discuss it with others who have different perspectives because I recognize they exist, that the most powerful weapons against stigma are literally unarmed truth and unabashed openness. I think that's the way we fight it, and I think we are doing it. And that's a circuit, that's a small system of the earlier version. It's now 31 of the cancer centers. Right now, I believe that we're probably the only comprehensive, trying to be at least, there is no designation from the government, and these are, but the comprehensive depression center. And I would love to see a network. I would love to see this happening around the country where the research is being translated into clinical care and where we essentially educate people differently. It made a difference for cancer. In 1954, the average survival rate for childhood leukemias was 3 months. It's now an 85% cure rate. That didn't happen through clinicians in their private offices. It will happen through focused efforts like these. And in summary, it's an illness. We can find it earlier. We can treat it better. We can sustain wellness. We can advance knowledge. We can fight stigma, we can support this network, that's my own thing, and in the process we will lessen the burden. And that's Julia saying, wow, Grandpa, this story isn't so scary once we learn more. And it isn't, it's actually very optimistic. So thank you, enjoy these 2 days, and that's it.